All right, welcome everyone to another Council of State Governments, Council on Communities of Color, Eastern Regional Conference, by the way, Micro Summit. This is another hashtag CSG COVID-19 Micro Summit. I'm Charles Ellison. I'm your moderator for this Micro Summit session that's happening this Friday morning. I want to thank everyone who is joining in and is participating as a panelist and also listening in as well. Just going to do a little bit of technical adjustment here. If there's anyone who currently is, I'm hearing a little feedback. I'm not sure if that's from the panelists or if that's one of the audience members. But if you have your volume up, if you could turn it down, or please mute yourself before we get this started today. For some reason, I'm hearing a little bit of feedback. I'm not sure if anyone else hears that as well before I introduce our panelists today. All right. Okay, well, welcome to the Micro Summit. Really appreciate everyone who's come in. We're going to go ahead and get this conversation, this discussion started. By the way, once again, I'm Charles Ellison. I'm host of Reality Check on WURD, also publisher of the vnote.com, and I am a fellow. I'm a fellow with the Council of State Governments, Eastern Regional Conference, Council on Communities of Color. For more on them, go to csg-erc.org, and you can find out more information on the Council on Communities of Color. In fact, the vice chair of that Council on Communities of Color joins us today. We're going to introduce her in a quick second. I want to give a shout out and a quick thank you to Debbie Ann Page, who is the director of that effort and also senior policy director at the Council of State Governments Eastern Regional Conference. Debbie, thank you so much for making this all possible and helping us facilitate this. Really appreciate that. So once again, csg-erc.org. For audience members during the course of this discussion, if you have questions or if you have any sorts of comments or any feedback that you'd like to give as the discussion is ongoing, please leave those questions in the Zoom group chat to the bottom right-hand corner of your screen. I will ask those questions out loud. I will relay your comments, etc. So definitely do that in the Zoom group chat, or you can have a conversation about what we're talking about today on social media, on Twitter more specifically, hashtag CSG COVID-19, hashtag CSG COVID-19.
We have to stop hearing you.
We are talking about healthcare equity gaps during this moment of pandemic, during COVID-19, and how those gaps, how those disparities in healthcare are impacting especially vulnerable, distressed, Black and brown populations, particularly those vulnerable low-income populations in many, especially urban centers throughout the country. I'm going to start introducing the panelists real quick. We have Maryland State Delegate Joseline Pina Melnick. She represents the 21st Legislative District in the state of Maryland. She joins us as one of the panelists. Also, we have Dr. Leon McDougall, who is President-elect of the National Medical Association. So he's a president-elect. He'll be starting soon as a president of his regular duties. Quite a way to kick off your new term as president. So congratulations on that. But you know, right in the middle of a global pandemic. Also, we have Kevin Ahmad Jenkins. Kevin Ahmad Jenkins is a professor at the University of Penn, and also is, and make sure if I get this correct, the Center for Health Equity Research and Promotion. He's the director there. He joins us also by Zoom. And Professor Usama Bilal. Professor Usama Bilal is a biostatistician and epidemiologist and a professor in the Urban Health Collaborative at Drexel University, joining us as well. Did some fantastic research recently on some of those testing gaps, those income or those testing gaps by income in the city of Philadelphia. And I know you're looking at some other cities as well. So let's go ahead and get this conversation started. Once again, for those of you in Zoom group chat, other audience members, please leave your questions and comments in the Zoom group chat. I'm going to start with you, Delegate. What are you seeing in terms of, sort of have a top line conversation here. I want to get the various participants' sense of what they're seeing in terms of these healthcare equity gaps that we're talking about? Well, first, let me ask you, Delegate, when we talk about healthcare equity gaps, what do we mean by that? What's the definition in your mind?
Well, in my mind, when I think about that topic, I think about the number of African Americans and Latino that do not have access to healthcare. I think about the disparities that are reported and the lack of data that we have. I think about how we as people of color are affected tremendously whenever we have a disease and illness. And I think about how we have implicit bias, how we have decades of adverse social determinants of health, how we have all these biological factors, risk factors, how we struggle in poverty for generations and generations. We have limited jobs, limited social mobility. We cannot and do not have the jobs where we can work from home, like many of us. We take public transportation. We lack, personal protection. It's just that as a policymaker, and I'm seeing what's being reported, it really upsets me because whenever we introduce a bill, the first thing people discuss is the fiscal impact. What is it going to cost? Well, the cost of losing lives is a lot higher. So as policymakers, we have to make sure that we have targeted resources, that we look at where are the gaps in the community. We don't need another task force to study this. We don't need another to study this. We know that there's an issue, okay? And that we don't pay attention to our communities of colors like we should. Oftentimes we are an afterthought. So it's a very complicated issue, but it's one that after this pandemic, we need to address because it will happen again. And the disparities are there. The numbers don't lie everywhere.
Dr. McDougall, I'm going to have you jump in. So, we are starting to have a much more pronounced conversation just in the past week or so about how COVID-19 is disproportionately impacting Black populations. In fact, Black populations are getting hit the hardest. So in your mind, is that in a positive way? Is that increasing awareness around these healthcare equity gaps? Is that doing what is a conversation heading in the direction it needs to? And also would like to get your sense of that definition of healthcare equity gap. Like, what are we talking about when we say that?
I think your audience would be happy to know and that the National Medical Association and the Rainbow Push Coalition led by Reverend Jesse Jackson recently published a manifesto, so a public health emergency manifesto in response to this COVID-19 crisis. And it provides actionable steps that our communities can take to help mitigate these disparities that we've noted with this global pandemic. In regards to answering the question about healthcare equity and its relationship to this current crisis, the gaps are numerous. And let's just stay with screening, okay? So you're an African American, Latinx, American Indian, Native Alaskan, and you're having some upper respiratory infection symptoms, and you call into perhaps your primary care physician if you happen to have one, and they say, hey, we're not seeing patients in the office now. We've switched to telehealth to facilitate these care encounters. With you having the symptoms that you are, here's a phone number for you to call the COVID intake center where there's a nurse on the line, and so Charles Ellison, you call in and there are some questions that are asked, and it's almost, I'm an educator, so I kind of equate things to tests. So it's almost like a test. Okay, so if you don't pass that test, you don't go to the next level of screening in regards to getting that nasal swab. And so what we're seeing just at the very origins, when we're talking about that gap, there's been reports that European Americans are being moved on to the next level of testing more often than people of color when they call in or are being assessed in regards to that screening that's at the very beginning, because the resources are scarce, right? So people are trying to conserve nasal swabs and assay to do the viral cultures. So mark that down, that's one. Now, another step. So Charles Ellison, we've determined that you should be screened. So what we'd like you to do is go to our drive-up center on such and such road. But ma'am, I don't have a car. So what's the next option for me?
Right. Dr.
So
I get the point on that too. And no, that's useful, because a lot of people have been asking, okay, about that jump from the testing part. Well, first, there's the big question mark of, can I get tested, right? And then, okay, if I am tested positive or confirmed positive, what happens next? What's the transition from testing to treatment? What's that like? And how equitable, how fair, and also how open or transparent is that? Dr. Bilal, and then I'm going to go to Dr. Jenkins, and we're going to try to open it up here a little bit more. Dr. Bilal, you've been looking at that as far as those testing disparities. You look more specifically at Philadelphia. There is a problem in Philadelphia. Like, you have like high rates, high infection rates, high death rates, and particularly the low-income Black neighborhoods in Philly, but you don't have a whole lot of testing sites. Still to this day, even after controversy surrounding, or you exposing that, hey, there's some, lower income folks are not getting tested as much as higher income folks. Speak to that.
Yeah, thank you. So what we keep finding, and this hasn't changed much in the last couple of weeks, but what we keep finding is that the amount of tests that are being conducted in poorer neighborhoods is much lower than in wealthier neighborhoods, and we've seen this for Philadelphia. But we've also seen that in those same poor neighborhoods, the likelihood that one of those tests is positive is much higher, indicating that potentially there's a higher burden of disease there. Now, it's very hard to be able to confirm that unless there is more widespread testing and unless the testing is more distributed. And actually, if we look at New York City, where the testing is a little bit more widespread because there's a lot more testing, because there are a lot more cases, the incidence of the disease is much higher in poorer neighborhoods. So we will expect something similar here in Philly, because the determinants of that exposure and the determinants of suffering the consequences of those diseases are the same everywhere. Are racism, are living in poverty, are living in overcrowded conditions, taking public transit, et cetera, et cetera.
Dr. Jenkins, have you been satisfied with the level of discourse we've been having around these racial disparities in terms of the testing, the treatment, in terms of the overall impact of COVID-19? So I feel like there's, on one hand, it's great that we have suddenly this increased or heightened awareness of the struggles of Black communities dealing with COVID-19. We could see this even before it became a headline about a week ago. But there's some problematic dimensions to that conversation. Talk about that.
Well, I think you're so on that. So we keep talking about coronavirus as a war. We're at war with coronavirus. Well, bottom line, if we're at war with coronavirus, the African American was ambushed. The African American community was ambushed. We were sitting ducks, not because of race, but because of racism before this. So now we're having conversations that are simply telling us that, oh, we're going to help you through a stimulus check. $1,200 for a family that, quite frankly, that may be a week or 2 weeks of pay, maybe, but it's going to take 2 months to get the check. But then on top of that, we have 1 in 6 African Americans are unbanked. So even just not having a bank account, those are problems, right? So we're not just talking about being ambushed, clinically with the overburden of the diseases that predispose us. We're also talking about being ambushed through our socioeconomic spaces, where we're talking about the fixes that have been given to us, if you will, as it regards to going online and using the internet for certain resources, when half of the people that are in the 45%, give or take, of African Americans that are over the age of 65 don't even have broadband internet in their homes. Our children aren't learning. A lot of our children are sitting at home trying to learn through Zoom, right? But they're learning on Zoom with a cell phone. Right? So we're not just simply talking about the clinical implications, but then we get to the testing. Let's talk about that testing. I'm going to piggyback and tag in with you, Dr. McDougall, because I think there's another piece to that we're talking about, even in the law, the fixes that they said for testing. Let's be honest. They said, if you're insured. Well, then we have to deal with those who are uninsured, those who are living in extreme poverty, who they may fall in for the testing space, but they're not going to even get access to those things that they need. Again, if this is a war, we were ambushed, right? So I just think that we have to keep framing it. We have to keep coming at it and keep thinking about what are the equity fixes that we all have to do, because and I'll end here, but when I think about all of this, Thurgood Marshall said it best when they invited him for the bicentennial for the Constitution. And he said the Negro was enslaved by law, was emancipated by law, then segregated by law, and now has begun to get his equality by law. So full stop. But I'm sitting back saying, well, if that can happen by law, why should we keep waiting on the law to help us? Right? There are going to be some things that we have to do as well as a community to pull together and start making sure we keep doing things like this, and we take that discourse further than just saying, pointing at the fact they're doing us wrong. We know they're doing us wrong, but how can we do right by us?
Yeah, I want to get into a conversation about that later, about the solutions or about potential fixes. And some of those fixes are obviously at the grass tops and what the policymakers have to do, and then there's those fixes at the grassroots, what communities can do. We're going to get into that a little bit later. Delegate, I want to have a broader conversation. I want to start off with the delegate about these inequities and also the systemic racism and implicit bias that Black and brown populations already deal with before pandemic happened, right? So we're in an environment where the public discourse basically says that health professionals, doctors, nurses can do no wrong, but certain communities know better. It's been a very complicated relationship. How do we reconcile that? Suddenly Black and brown communities, those vulnerable communities, suddenly have to go back to and depend in real critical ways on those systems that have so much bias, that have so much systemic racism within them already. How do we reconcile that? And what have you been hearing in like your district in a state like Maryland?
Look, our governor has been very aggressive regarding from day one to make sure that people stayed home in every policy and order that he has issued. However, I think that before all this happened, we were talking about implicit bias. We just passed a bill in Maryland regarding maternal mortality, right? Where Black women died 3.7 in Maryland, more than almost 4 times the number of white women, during childbirth or during that first year. So we passed a bill that require implicit bias training for healthcare workers. We also have passed a bill dealing with cultural bias training, right? So we know the problems were there. And after this is done, we need to go back to that discussion. And actually, we need to be having conversations about what we're going to do. How can we make healthcare be more equitable, right? How can people have access? because we have all these barriers. And I know that we're having a discussion here with the NAACP. When you talk about community, right, with the NAACP, with the Latino community, with all the health officers in Maryland and legislators, and we started the work already. We have a talk on Saturday at noon where we are going to bring experts and try to plan and have a course of action to make sure that our communities are covered, to make sure that they have access to health care, because it's not the same. Even when you think about Medicaid, which is the public insurance for the state, for people that are not able to have private insurance, we still have gaps there where we don't have enough primary doctors, right? Where not everyone takes Medicaid, right? So we just need to revamp our system because we are paying for that. And as policymaker, it is really important for us to know where those gaps are and those resources, and to hold our healthcare providers accountable. Okay, when we reimburse, to make sure that we have certain criteria and that they're measuring it and that they follow up and stay in touch and communicate with the people they serve. Some people are on Medicaid and they haven't seen a doctor. Okay, we need to follow up and make sure at the very least that they stay in touch. There's a lot to do, and we're in Maryland, we're ready to do it.
Mm-hmm. Yeah, Dr. McDougall, how do we reconcile those disparities and the implicit bias of systemic racism that's already in the treatment? You're a practicing doctor. You also see that you're in touch with various folks who are on those frontline medical professionals. What are they telling you? What are also Black doctors and Black nurses telling you in terms of what they're seeing from their white colleagues in terms of identifying a lot of those biases that had already been there to begin with before we had even started getting into a pandemic? And that obviously creates problems when we get into that treatment phase. And then we start having conversations and people are starting to have suspicions, or I'm hearing anecdotal evidence, or I'm hearing even legislators, policymakers like yourself, Delegate Melnick, who are having direct conversations with hospitals who are saying, or hospital professionals who are telling them, hey, yeah, you know what, I'm seeing some things that are making me uncomfortable in terms of how ventilators are being used or distributed. So talk a little bit about that, Dr. McDougall.
Very good questions, Charles Ellison. So as President-elect of the National Medical Association, we represent the collective voice of 45,000 African-American physicians, and we have collaborated with Reverend Jesse Jackson and Rainbow Push in putting together a public health emergency manifesto, which I highly recommend that all the participants in this group meeting will take a look at. It provides actionable steps to address the concerns that have been voiced here today. One additional point I would like to bring up is that of workforce diversity for our medical professionals. Only about 4 to 5% of physicians nationally are African American. So when you speak to cultural competency and even proximity, or wanting to and having a desire or a calling to practice in those under-resourced multicultural communities, that's where members of the National Medical Association are at. So when we talk about legislative issues, full support of Title VII and funding health career opportunity programs, being more expansive in the pre-K through 12 education pipeline in regards to perhaps creating health sciences academies in affiliation with the local medical schools. And as you all probably know, there are 154 medical schools in the United States of America. Most of them are in urban communities, and to increase that partnership with medical schools and the local elementary and high schools and middle schools, I think that's important. So look at that manifesto, but these are just some of the things we've addressed.
Yeah, Dr. Bilal, and I'll ask you this too, Dr. Jenkins, on this. We did get a question. This is a good one. And audience members, you can start inserting questions if you haven't already in the Zoom group chat. I will ask those questions. I also will read out those comments as well in real time and live time through Zoom group chat. That's how we're going to facilitate the audience member question phase as we continue this conversation with our panelists. Dr. Bilal, we have Dr. G.S. Potter, and Dr. G.S. Potter joined in, and she's actually a regular contributor on Reality Check on WURD. But she asked a really good question here. She makes a really good point. You know, we've touched on people that make the phone call and get turned away from medical centers. But what about the folks who aren't even trying? There's a large number of people who are living in what are called healthcare deserts. And either those folks have already, you know, they already don't have health care, and they've been turned away from treatment because of racism or because of implicit bias in the past. So what about those large pockets of potentially COVID-19 infected folks who are very reticent, you know, very reluctant to access a healthcare system, or there's not a whole lot of healthcare system to access around them? How do we track those populations? Let me start with you on that, Dr. Bilal.
Thank you. So I think it's important that we consider that this is not this epidemic has only made it very clear that there are many issues in the way we organize society and in the way we organize our healthcare system. So what we are seeing are just the acute manifestations of that type of organization. If we have a healthcare system that focuses on unemployment, then when people lose their jobs, they won't have access to this. If we have a society that has discriminated against a group of individuals for centuries, then this is what we are going to see when a crisis comes. So with that in mind, what we need to be very mindful of is that there are communities that have never had trust in the medical system because the medical system has failed them throughout decades. There are communities that don't have trust in the government because the government is the oppression force. And in terms of this specific question, my key worry here are, for example, people who are undocumented, who live in constant fear of being deported, being caught by ICE, in some states, even being caught by their local police because they have agreements with ICE, etc., etc. So how are we going to expect all of these people to then go and get tested? How are we then going to control this epidemic? This is not going to work unless we fix that. Now, how do we fix that? It's a completely different thing because we are talking about 4 centuries of this. So we are not talking about something that really started 3 months ago. This is something that has been brewing for the last 4 centuries. So that's something that we need to be very conscient about. That this is not something that just started now. And what I also want to say is that we need to be very careful with the kind of advice that we give out. Like I have right next to me that I guess most of you got this kind of postcard in the mail where, you know, you got all of those advice on what to do. And if you read this, it's like most of it is completely, the tone deafness of this is incredible. If someone in your household has tested positive, keep the entire household at home. Like if you rely on your daily job to be able to eat, can you do this? If you are an undocumented worker who has no access to employment or health insurance, you cannot do any of this. So we need to be very careful with all of that, and also very careful with the kind of narrative that we have going around. And that's the last thing I wanted to say with regards to this is, I'm guessing most of you remember the comments by the Surgeon General a few days ago when he was saying that people of color, in particular, he was talking, I think, to African Americans and Latinos, saying that this is the moment to avoid drugs and to avoid alcohol and to avoid other things. And when you hear that, what the narrative that is being created is that this has been brought on African Americans and Latinos because they didn't behave as we expect them to behave, because they don't do drugs and they don't do alcohol, etc., etc. So by creating this kind of narratives, what we are doing is placing the blame of the people that are oppressed instead of placing the blame in the way that we are organizing society. So we need to be very careful with that, because from the medical profession, from the public health profession, we sometimes can give advice that actually works very much against all of these communities.
Yeah, Dr. Jenkins, talk about those healthcare underserved populations that are already they've had very bad experiences with the healthcare system to begin with. So obviously that poses problems in terms of how we can track infection rates, track how severe cases are. Talk a little bit about that. Follow up on kind of what Dr. Bilal was saying, and we'll also throw in some other questions I'm seeing here in Zoom group chat.
Thank you for that. This is actually so interesting. So there was a study that came out that talked about 1 in 3 people who experience discrimination will distrust the medical facility or the medical institution as a whole. Mm-hmm. But then when you do a little bit more digging and look at the other research that's coming out, specifically up to 82% of Black and brown people have experienced racism. Right? So that just gives us a baseline to understand that probably a third of us are already a little sketchy and shaky about these ideas. One of the reasons why we're dealing with this issue the way we are, the president made a very interesting comment among many, where he tried to say that this was a medical problem. That's what he said. He called this a medical problem. And what a medical problem is, what medicine is as it's defined, is medicine in itself is about working for a provider, working with the patient, dealing with the health issue at an individual level. If you frame this as a medical issue, it becomes the patient's responsibility to care for themselves, to do all of the things they have to do. Public health is about the public's health. And the person who's the doer, the agent in this, is the federal government or the governments. So by making this a medical problem, what it does is effectively shifts all the blame to the individual and takes it away from our institutional government, right? Mm-hmm. So by not framing this as a public health matter, what it's now doing is it's providing strategies that don't work. It's providing strategies that are all over the place. It's providing strategies that are doing nothing more than just playing footsie with the distrust we already have. So when we keep thinking about this issue, the discrimination issue, when we think about the gaps and the fear and the terror that's going to be asserted when they say we're going to open the country back up, and guess what? Folks still have to go to work. I know I'm not the only one going in that grocery store, especially like last week. It looked a little better this week, but last week I was watching those little kids, those teenagers working in my local grocery store. No mask, no nothing. And there was a man that walked up to this one young lady. She couldn't have been more than maybe 18, 19, working. And he's like, doesn't care about social distancing because he doesn't see her. He sees someone providing a service for him. Mm-hmm. You know, and I just yelled at him because I'm sorry, I'm a shot no chaser if you can't figure it out. I yelled, I was like, man, back up. You know what I mean? Back up. You could see the fear just go over her in that quick moment, you know? And it's just like, they don't see us. And I just want everybody that's listening just to know that our voices matter. Our voices matter. And even if it seems like people aren't listening, we got to keep talking. We have to keep talking, but make sure that we're talking to each other. So if you know someone that is dealing with some symptoms or issues, find ways to just talk them through it so we can get you to get the help you need. This is not an individual problem. This is an institutional problem. This is a public health problem, not a medical problem.
I'm going to open up the floor here a bit, so I can facilitate questions from the audience. So, definitely encourage the panelist members to jump in. And Delegate, this is probably a good question for you. This is from Cassandra Basler. I hope I'm pronouncing the name correctly. She's a journalist out of Connecticut. She's wondering about those persistent state public health gaps or data gaps. What can be done to ensure, and we've been having a conversation, and actually there's legislation that's been introduced in the House, in Congress, demanding that states deliver or submit more granular race and income data of COVID-19 infection rate cases and also deaths. So what can be done to ensure that states are collecting that necessary data? What can be done on the policy level, like a state like Maryland? Is Maryland collecting that data, by the way?
We are. So what can be done is, for example, one of our members, Delegate Nick Mosby, actually led an effort of all the, he sent a message, an email to the Black Caucus members asking us to sign a letter demanding that the Department of Health release this data and collects the data, right? As we were testing, because we were not doing it. So his effort to lead this, we all signed this letter. We started making calls to the governor's office. As a result, the governor last week held a press conference where he required that at least the state labs start collecting the data. It's more difficult with the private labs, but the state labs start collecting the data. So as legislators, you often see that we put forward certain bills requiring data collection, on how many people are stopped, by the police. Can you keep track of who's being stopped? People that are going to the, to the doctor, who's using Medicaid, who's not using it, what is the number of women that are dying? Like we often, as a result of childbirth, we often, as state legislator, put in all these bills requiring the department to do it. But, we should not have to put those bills, right? You shouldn't have to legislate common sense, but we often have to put them in to require all these different agencies. And what you're going to see, and I was thinking about that this morning, is that you're going to see a lot of bills from a lot of our members, requiring all this data. And I think legislate so that it is in the law, it is codified, it is a requirement, and when you get a new administration, they don't change it. So we're going to do that. You're going to see that happening all over the United States.
Yeah, anyone, feel free to jump in on that question too. And the other thing I think it's good to talk about is, and Dr. Jenkins, you had touched on this just a few moments ago about the need to persist with this conversation, to keep putting the pressure on the public discourse, because folks will give us will sort of impress upon us or try to make it seem like this kind of conversation isn't necessary. Why do we need to identify the race or the income of the people who are impacted by COVID-19? No, that's a very necessary conversation. So speak to that, and anyone can jump in on this. Speak to that. Like, why is this a necessary conversation? Why is it so necessary to collect that kind of data to also identify or to highlight these testing and treatment gaps?
Bottom line, Audre Lorde said it best, that the master's tool cannot dismantle and will not dismantle the master's house. And the best tool that we have is data right now. And this idea that if we disconnect and talk about it after the epidemic, after the pandemic's over with, that means we've already died, right? Mm-hmm. That means the consequences have already been levied upon us. So if we're not moving in real time, if we're not doing these things in real time, having that discussion, sounding the alarm, if we keep waiting, basically we're going to keep piling up those death tolls in the communities that matter, and you forever fracture the trust in this system. And I think another piece that just scares me so much about it is that we when this thing first started, there was this idea that Black folks didn't get it at all. And then when that disparities data trickled out, next thing you know, everybody's like, oh my goodness. And then it was a faction that said, I don't believe it. You know how this goes. And you can't be on both sides of that fence, right? You can't post an article that says, don't trust the government, anything they say, but then post another article that says, hey, stay woke, because this young man up in Michigan that was killed because they wouldn't allow him to get a test, Basie, that died at 25 years old, that had a fever, shortness of breath, and the fatigue. They dismissed him and said he had bronchitis. They told him to go home, right? And over a week later, he was dead because of coronavirus, right? So if we wait, we're going to be missing those stories. And I think overall, if we don't have a narrative with the numbers, that's why these discussions fall flat. We got to have a narrative with these numbers.
Mm-hmm. Go ahead, Dr. McDougall.
Mr. Ellison, I'd like to jump into this. So going back to the earlier question about reaching the community, that involves engaging trusted messengers. members of the National Medical Association, members of the Black Nurses Association, members of clergy, community health workers, packaging that within a public service announcement, multilingual, culturally sensitive, in regards to establishing mobile testing centers that are within a walking distance of functioning bus stops and train stations. So all of these things are in the manifesto that I keep bringing up with that collaboration with the Operation Push and the National Medical Association. So that's what I'd like to add to that.
Oh, I'm sorry. Did Delegate Pena Melnick or Professor Bilal, did you want to jump in on that? You know, as far as why is this a necessary conversation? I'm also going to throw in a question. Well, while we are on data, because data seems to be a big piece of this. John Erickson, he's with I think it's the Rensselaer Polytechnic Institute, and he's saying that the RPI has published a tracker, a COVID minder tracker, as he calls it, and they're highlighting COVID-19 disparities and outcomes, determinants, and mediation. So they're trying to uncover that data, but very few states are publishing the key comorbidities like hypertension, diabetes, that are indicative of that bias that we're discussing. So how do we get better data now? Because obviously it's a long-term conversation about how we finally reach a point where all 50 states and the territories are collecting that kind of complete data. But thank you for that question, John. How do we collect better data now? And you think it's some real good points about, tracking the comorbidities, et cetera. Who wants to jump in on that?
Yes.
Oh, go ahead. Oh, hold on one second. Let me see the delegate here. I think she's.
Okay.
Oh, go ahead,
I know
delegate.
that in Maryland, we started collecting the data after the Black members, put a lot of pressure on the governor. I think that we also started working with our different municipalities, and they were requesting the zip code so that they can know where do we start doing better messaging, what resources to put in. And we had to fight for that as well. So we finally were able to get it, because what happened was that the law states that the Maryland Department of Health has to give that information to the local health officers. We have 24 counties, 24 different health officers. But the local health officers were not required to give that information to local government, to the municipalities, and we have a lot of municipalities. So we had to put pressure so that they release the data by zip code. So now you're starting to see that, where the different counties have the websites with a zip code, so we know where we have a high concentration, and then the local government can go ahead and put resources into it. Look, the bottom line is that we need to do better, that we need to demand it as legislators. It is upon us, our responsibilities, to make sure when we go back in session to put in bills that require this data reporting. And meanwhile, we're not in session to write letters, to call the governor, to work with our local partners and nonprofits and the churches and make demands of the government. Because when we get that data, then you're able to tell who is affected. Clearly, we are being affected, people of color, but where are the gaps? What are the resources that we have? For example, we're getting a lot of money from the federal government. How do we ensure that that money comes back to our communities, that our people are being protected, and that we're putting money in those communities that need it the most? And that's why the data is important.
Dr. Bilal, Dr. Jenkins?
Yes, I wanted to add that the political pressure to release this data is key, and I think the data only started to come out when the narrative started shifting. Like, oh, we are starting to see this case here, the other case there. Like, those kind of stories help a lot in getting the data out, because then it was journalists, it was people, it was
That's right.
non-profit organizations that started asking local governments and state governments to release this kind of data, which they are collecting. In the case of the death data, it's on the death certificate, so they are collecting it. In the case of the testing data, we have to make sure that they start collecting it, and if they collect it, as I'm sure that they do in most cases, that they are releasing it in a way that we can use it. So political pressure is key, but it's also key that we remember that not every group has that kind of political power.
Right.
Like a lot of differences even among marginalized groups in the political power that they have. So we need to make sure that we find the pockets of groups that have the least power. And I want to go back to the idea of undocumented workers being some of the most affected because they have the least political power of I will say of many of the groups. So it's key that we remember these groups that have very little voice in order to be able to ask for that data too. Now, how do we collect data on people that are invisible to society? Is a very, very tricky thing.
Yeah, Dr. Jenkins. Yeah.
Yeah, I think there's an underlying piece because when I think around mid-March, right before we started getting data, that's when we were all asking. I was on social media going crazy about it. I had people from all over the country asking questions like, do you have the data? Do you have the data? Do you have the data? One of the things we heard was that part of why there's such a disconnect as well, there's no national strategy for testing for one, right? So because of that, when you show up to your provider, let's say everything's good, you trust your people, you show up to the provider, they're like, no, our new protocol is you go to, let's say, I don't know, some place around the corner or whatever. That's disconnecting you from your electronic medical records, right? So the information that you're giving the folks is kind of the cursory, like, let me get back to you. So once we figure out what's going on with you, so that delay between them telling you what you have or not have, it has to then get back to your provider. That it's like we're literally seeing a disconnect all around this horn because basically it's no coordinated effort to talk to each other. So that's a part of that data issue that we're also seeing. And then the other side of it is that we have to have leaders in place that actually want the data to come out where it is available. So again, like everyone's been saying, we have got to put our foot on the gas. There's no reason to let up. I'm not worried about how articulate it is. We have to fight, we have to fight, we have to fight. And we have to make sure that we get the information for our communities so that we can get the resources for our communities. So that's really what this is.
We had a question from Connecticut State Representative Robin Porter, and she was saying that the members of the Connecticut General Assembly, both the House and Senate, have requested that data collection as well. She's asked specifically that zip codes be added to that data collection. She's saying that what's disturbing is what's being reported by local funeral directors is that the numbers are not accurate due to the fact that on death certificates, the underlying conditions are being listed, but not COVID-19. So, and this goes back to that conversation that the infection and death rates could actually be higher than what we're seeing right now. The reason being that many Black and brown people are not being tested and are dying at home. That's another big challenge, another big problem as well, and exposing entire families to the virus. So Robin Porter talking about what's happening in Connecticut, talking about the role of, funeral directors. And then there's that problem of there are a lot of folks at home who are dying at home. We haven't really gotten a real firm grasp on those numbers. I see you shaking your head, Dr. Bilal.
Yeah, so I just wanted to add that even if we don't have a precise ascertainment of what was the cause of death, some of the things we can do is try to compare to previous years, to the same week a year ago, the same week 2 years ago. We expect that nothing else other than the coronavirus has changed. So if we see a gap there, and especially if we see a gap that is differential by zip code, or a gap that is differential by race and ethnicity, then we can start to tackle all of these things. And I know I'm from Spain, and Spain has a daily mortality monitoring system where daily we can see the number of deaths as reported to funeral homes and to civil registers. So what that allows us to see is daily, even if we only tested 100 people and only 100 people have been confirmed to die because of this, we can see the gap. We can see the gap by many characteristics. Now, is there a system like that here? The CDC has a similar system that has a big delay in reporting. So there are all of these things of public health underfunding. What they end up causing is that we are kind of blind. We are trying to look at data. Some of it is there, but it's not released. Some of it is not even collected. Some of it is not analyzed, and there is no central coordination of this at all. So that's something that we need to address, because whenever we don't see anything, it's usually the most vulnerable people that end up suffering. Whenever we have a scarcity of resources, a scarcity of data, that's always what ends up happening, because that's the people with the fewest amount of voice. So therefore, we need to have the data to be able to help them speak up.
Also, before I have any of the other panelists jump in, that link was provided. Thank you, Debbie, for this. That manifesto that you were talking about, Dr. McDougall, that you did in conjunction with the Rainbow Push Coalition, that's been provided in the Zoom group chat. It is at nmanet.org for more information on National Medical Association. But thank you, Debbie, for finding that manifesto that the Dr. McDougall was referencing. Also, thank you, John Erickson, at the RPI, the COVID Minder tracker that he was describing. He also put the link to that tracker in the Zoom group chat in case folks want to access that there. We're going to continue fielding questions and comments from audience members. We have Martin Pratt. Martin Pratt's also a Council of State Governments, Council on Community of Color Fellow, Eastern Regional Conference, by the way. Martin is saying, I'm seeing 3 strikes for turnaways with a lot of Black patients, and he's coming out of Philly, actually. I'm seeing 3 strikes for turnaways with a lot of Black patients dying after that 3 turnaway, even in the case of a Hispanic police officer. I don't see anyone responding to this policy. So he's identifying limits that are being imposed on people who are going to testing sites. Delegate and others, do you want to address that? Are you saying that as well? Like you're in suburban DC, basically, Delegate Pina Melnick. And so you're in highly urban, suburban areas of the DC area. Talk a little bit about that if people are also experiencing some of those same challenges.
Yeah, and I actually, I have a personal story of a cousin actually in New York who went to the hospital on Sunday, and I actually managed to talk to his nurse after we tried like 100 times, and I know they're overwhelmed. And then she gets on the phone, and I did a third-party call with his wife, and she says his oxygen is fine. He doesn't have a fever, although his breathing was labor, and we're going to send him home. So, his wife couldn't pick him up. So basically they were going to put him in a cab and send him home. He got home, and I got a call yesterday afternoon that he died at home. Okay. He passed away, a young man, in his 50s. It's very frustrating because I have another case of a young lady who actually works for the Maryland Legislative Latino Caucus who, a family member wasn't feeling well. They did the telehealth, and the doctor was like, you're not experiencing the symptoms, stay home. And then again, the person's not feeling well. They get on the call again with the doctor. And it seems like you have to really convince people to take you seriously. And I don't know I know that some of that is the bias. Some of it is with the one person I helped on the phone by calling the hotline because they don't have a primary doctor. So when you don't have a primary doctor in Maryland, you call the health officer, which they're wonderful. But I made the call with that person. I was on the call in Spanish, trying to translate. And he's telling her he doesn't feel well. And she says, well, you don't have all the symptoms. Someone's going to call you. Well, then you're putting a barrier there. I think that it shouldn't be that complicated. It should be a lot simpler for people to be able to communicate with a doctor and to be tested. Everyone should be tested. That's the bottom line. Everyone should be tested. But our people are not being tested because of lack of health care, lack of communication, okay, and not be able to be persuasive to make their case. It's as if you need a lawyer to be your mouthpiece, and it shouldn't be that way. It should be easier.
To that point, I might, go ahead real quick, Dr. McDougall, before I let you step in.
What we're
calling for,
the National Medical Association and Rainbow Push, is that a priority risk factor be assigned to people who have experienced disparate health outcomes, African Americans, Latinx, American Indian, Native Alaskan. If you are identified as belonging to one of those high risk groups, we would like that to enable one to obtain that screening test. That's in the manifesto.
How do we, real quick too, and I'm going to extend this conversation by another 5 or 10 minutes just to give everyone a chance to, I have actually another question, and I know that there are a couple of other people who have made some points. So hopefully our panelists can hang on with us for another 5 to 10 minutes while we continue this very insightful conversation that we're having right now. Folks can also, if you want to leave comments or share pieces of this conversation on social media, you can do that at hashtag CSG COVID-19, hashtag CSG COVID-19. Even after this panel has concluded, you can go on social media, have the conversation there. You can extend the conversation there, primarily on Twitter space. Continue to leave comments, feedback, and questions in the Zoom group chat. It should be in the to the right of your screen in your Zoom module. So just go to the Zoom group chat and leave comments and questions there. I'll be picking those up throughout the duration as we're going to add a little bit of overtime to this insightful, this needed essential discussion on healthcare disparities and testing and treatment gaps during this pandemic. Obviously, we could go on for even more hours, but we have very limited time, but we're going to carry it on for another 10 minutes or so. Go ahead, and I think there was some, with Dr. McDougall, you made that point. We had the manifesto. I am really curious about this. Dr. Jenkins, you had touched on this earlier about what communities could do. We're talking a lot about government, city, state, and federal. Obviously, there are limitations there. Some of those limitations are inadvertent. Some of those limitations are very deliberate. They're by design. What can folks do on the grassroots level? Like I'm seeing and I'm hearing in multiple cities, the creation of mutual aid networks, for example. So like we have that problem of people dying in their homes, like what the delegate just described. Well, very active mutual aid networks in a city like a DC, like a Philly, a Detroit, a Chicago, and I'm starting to see them pop up in response to this, can be very useful. And then Dr. Blau made that point of, some communities don't have that kind of political clout to get that immediate policy or political response they need in terms of the testing treatment gaps. Talk about what communities could do. And if other folks want to jump in and speak to that, that would be great.
I think clinically, one thing that we should focus on is just making sure that we're providing accurate information to our folks. And I mean clinically being where testing sites are available. If someone needs a ride, we need to try to step in and help out. If there are moments where, look, we know folks don't have cars. Instead of just saying, hey, it's not fair that this drive-up testing center exists and I don't have a car, can I help somebody to go there? We love Cash App. We love Cash App for everything else. There are a lot of people that are struggling. If you're ordering food from your local restaurants, you need to be tipping a little bit extra, right? These people are putting their lives on the line just to bring you something to eat. I'm talking about just basic things, right? But we're also talking about the kind of that psychosocial impact as well, because one of the things that we're looking at within the VA Medical Center, we're going to be looking and examining this very specific issue among end-stage renal disease patients who are on dialysis. They have to go get care in this craziness, right? A lot of people are missing dialysis appointments right now. Well, missing a dialysis appointment, one dialysis appointment missed can translate to a 30% higher mortality rate for this person. So we have to make sure that we're stepping in the gap for folks for the psychosocial needs, for those socioeconomic needs, but also just making sure we have accurate information. And I want to say one thing for our kids, because I feel like we hadn't talked about our children enough in this pandemic. Our children need us. They need us. We need, if you know somebody that's doing a webinar or Zoom call or something that's educational, that can take a little time off of mommy and daddy or grandmama or big mama, big daddy's hands or something, just for a little while, share that. so these kids can have a moment to also have a little normalcy in their lives, y'all. This is going to be a while just because of the disorganization, but we as a community have to remember during that 1918 pandemic, particularly in Chicago, one of the things that helped the most in those communities that look like us, what helped the most, even though we had limited resources, we helped each other. And we can't miss that time now.
Yeah, go ahead, Dr. Perdue.
Since we are in overtime, I'd like to extend this conversation to the prison and jails. That's a very emerging topic whereby with overcrowding and for example, here's something that we're talking about with the Rainbow Push, that example in Dallas with the number of people in jail that have not been convicted of a crime. Their crime is that they cannot afford bail. So we're advocating for those nonviolent offenders who have not even been charged or convicted or proven guilty, to allow them to be released on either personal recognizance, some type of home monitoring, or involving their system to monitor through parole officers and the like. This is just uncalled for, putting people at high risk in environments that the infection of COVID-19 could just run like wildfire. We're also advocating for persons who are incarcerated to have face coverings and access to soap, water, or hand sanitizer. So for looking at that community, that potential risk, I think that's something we really need to pay more attention to as this COVID-19 is rolling across this country and globally.
I'm real curious, Dr. Bilal, have you been tracking that data, or is anyone tracking that data as far as infection rates inside jails and prisons?
I have seen reports in the media, but I haven't seen any systematic data collection effort. And again, these are invisible populations that
Right.
It's very, very hard on normal circumstances to get any sort of health data from people who are imprisoned. Now it's going to be even trickier. So this is another representation of another invisible population.
And I want to just jump in on that piece, because right now, the Chicago, Cook County is being sued right now because they're trying to get those prisoners, those ones who shouldn't be in there right now, especially they want them out, because the infection rate is like 50% in Cook County jails right now. One of the largest facilities in the nation. Like, I just heard this on Wednesday with I can't tell where, but we just heard this Wednesday. On that same Wednesday, what I was hearing from those that are physicians and nurses that are in that space, that are saying 90% of those COVID patients that are coming are Black and brown patients, right? So we're not just talking about Illinois. I'm talking about my networks here in Pennsylvania, in Delaware, Jersey, New York, in some of these spaces, in some of those places. And then on top of that, right now, like Einstein Hospital right here in Philadelphia, they're slammed. And the money is running out, right? So they're furloughing workers at this point. You know what I mean? Yeah. So we have those issues as well. But I Dr. McDougall, thank you for bringing up the prisoners, because these folks won't have a voice, and they're going to be pathologized just by their presence. But I have to also say, this narrative is going on all across the country. So if you all really want to even dig into that, I wouldn't look for data. I would look for court cases, because that's what's happening. They're suing right now.
That's a good point. Also, Representative Porter says, let's be mindful of our juvenile detention centers. These are the most vulnerable children, and we do not want to leave them out. Also, Dr. Potter makes a real good point. Homeless encampments. homeless encampments also need special consideration. So we have these other populations that we just miss, that we don't have a conversation about. We have been having a much more vocal conversation about what's happening inside jails and prisons. I was talking to a former state representative, Movita Johnson Harrell, who unfortunately had been convicted last year. She just served a 3-month jail sentence. She just came out. She was just released last week, but she came on Reality Check on WURD to describe how tense it is right now inside those prisons. Inside, just her experience alone, just dealing with that for a few months before she was released. Speaking of Dr. Potter, I did want to throw this question before we end this discussion. Dr. Potter had made the point here that she was saying if we're being really straight no chaser, the federal government and many state governments are run by white nationalists. They are very comfortable running Black, brown, and indigenous bodies into the ground to support their economy. Genocide and slavery are our foundation. So we can create the bills, we can collect the data, and we should do that. But if we are under attack, how do we protect ourselves? What's the direct action? Do we mobilize our own tests? Do we do rent and work strikes? What do we do in a time when these bills and policies are a long game and they'll be fought against as well? And anyone can jump in on that.
I like to jump. So first of all is the prevention aspect of it and control that we have. So Rainbow pushing the National Medical Association, we're saying shelter in place, and that means at home. We're saying worship in place, and that means at home. Use social media, other electronic forms to stay connected, because as humans, we need to maintain that connection. So that's why we're going away from the term social distancing and replacing that with physical distancing, staying 6 feet away from folks, staying away from mass gatherings, wearing facial coverings in public. And a caveat to that, Charles Ellison, would be that African American males, we're recommending that perhaps either wear a white facial covering or a lighter colored facial covering because of that implicit bias that's in the community that may untowardly be directed towards especially African American males and put one in danger when they're just trying to protect themselves from a virus for which there is no treatment. So some of those washing your hands, and I got a quick story about this in regards to hand sanitizer. You probably heard there's been recommendations that was really pushed earlier in this discussion. So I went to the store and looked for hand sanitizer. That shelf was completely bare. But Charles Ellison, guess what? I turned my head to the right and there was all kind of hand soap and hand soap dispensers. So washing your hands 20 seconds with soap and water is effective too. And you shouldn't be shaking anybody's hand to begin with, and cleaning off, surfaces and so forth. So so we do have some control in regards to mitigating these circumstances that we're in now. So I just wanted, in closing, I guess I just wanted to share that with you.
Yeah, that's essential information. Go ahead. We're going to go ahead and wrap it up. Well, I think the delegate would just make sure we unmute the delegate here. Delegate, you had a point you wanted to make real quick?
Yeah, I wanted to say that what we also need is that we need a lot more people like us in these positions. We need to make sure we elect people of color to these offices. We need to make sure that we are in those rooms where the decisions are being made, and that we remember where we come from, okay, when we deliver this message. It's really important. I know in Maryland, we don't have, out of 188, we only have 4 Latinos out of 188 that are in the General Assembly, when Latinos in 2010, when the census was done, were almost 10% of the population. Okay, that's just not right, because if you're not in the room, you are an afterthought. Okay, and that is important as a community for us to, keep that in mind as we move forward. These elections come up as well. I want to say that in Maryland, Chief Judge Mary Ellen Barbera late Tuesday ordered the trial courts to identify and release prisoners statewide who are at risk for the coronavirus and pose no threat to the public safety. I think everyone should demand that in every state. In addition, the federal government and the Democratic Party and a lot of us have been demanding for Governor Hogan to make sure that some of these prisoners are released as well. So what we could do, we need to work together. We need to put pressure. We need to use our voice. We need to use the power of the pen. And we need to keep the conversation the conversation going, because we tend to have a short memory. And we need to keep it in the forefront. And that is up to elected officials, nonprofits, the church, also reporters, all of us. We need to do that. It is important.
Oh, Dr. Jenkins, you were throwing a comment in while we close.
Yes, I want to make sure I address white supremacy, because this is important. This is really important. It's important for us to understand that as someone who examines the impact of race and specifically racism on our health and healthcare and our clinical decision making, we have played this game where we think we can keep pointing, when we tell on somebody to say, did you see what just happened? Yeah, I know y'all saw that. Every time we say something, nobody's watching. In this moment, right? I think the equivalent of what's going on is the same equivalent to police shootings that we're seeing, where people are dying on camera, where it's indisputable what happened when you can die with an illegal chokehold, and yet the only person that gets indicted is the person that's literally holding the camera. We're in that moment again. But now it's our health that's at stake. If we let these numbers just continue to balloon and no one's paying attention, it's literally going to be that our folks are dying with no indictment on our government, no indictment on the leaders and the voices that should be helping us. If you read the CARES Act, my research lab just finished evaluating the CARES Act, which is focused on this whole response, right? And the thing that you'll see riddled throughout, over 177 times, is per the secretary or the secretary shall. And remember who our secretary is, and remember who his boss is. And remember that if they don't want to do it, even though it's been appropriated and all that kind of stuff, they don't have to. So all I'm saying is we cannot let this go with no indictment. Not again, not today.
All right, I don't know if anyone had any parting thoughts before we wrap. Dr. Bilal?
Yep, I just wanted to add a last thing, which is that I just saw that a few minutes ago the Johns Hopkins coronavirus tracker has started a new webpage that shows which states are releasing race, ethnicity data for confirm and death. Wow. So I will leave the link here in the chat. So I think this is a great resource, because I'm seeing here only 26 states are releasing race ethnicity data for coronavirus deaths. 26 states only.
All right. No, thank you for that. No, please leave that link there. Dr. Usama Bilal, get the last word. And as he just left the link to the coronavirus tracker at Johns Hopkins University. And now they're providing state by state data showing who's collecting that more granular race and income data. Usama Bilal is professor in the Urban Health Collaborative at Drexel University in Philadelphia. He gets the last word on this special panel that we convened today. Also, you heard earlier, Dr. Kevin Ahmad Jenkins, who is director of the Center for Health Equity Research and Promotion, also teaches at University of Penn. You've been also
promotion. I'm just an investigator. Don't give me too much of a promotion.
Just an investigator.
I got to get my check in 2 weeks, because the real director signs that. I'm a core investigator for the VA as well as a lecturer at Penn.
Thank you for that clarification. I appreciate that. All right. Thank you so much. Also, Maryland State Delegate Joseline Pena Melnick, who represents the 21st Legislative District in the state of Maryland, and she is also Vice Chair of the Council of State Governments Eastern Regional Conference Council on Communities of Color. So she's been joining us, as has Dr. Leon McDougall, President-elect of the National Medical Association, representing, I think it's near 60,000 Black doctors throughout the United States. Is that correct? Is that correct, Doctor?
45.
Oh, 45,000. Excuse me. Okay, I inflated the numbers a bit, so I got to be careful of that. But no, I appreciate you. Appreciate everyone. Also, you can reach. I'm just going to give out your Twitter handles real quick. Usama Bilal is at Usama_Bilal on Twitter. You can engage him there. Delegate Pena Melnick is at JPena Melnick, JPENA MELNYK. Also, Leon McDougall is at McDougall 2020, and Dr. Kevin Ahmad Jenkins is at KJ Answers on Twitter as well. I'm at Ellison Report on Twitter. You can catch me there. Also, to learn more about the Council of State Governments Eastern Regional Conference, go to @CSG_ERC and hashtag CSG COVID-19 to continue this discussion as well. I want to thank the panelists. Thank you so much. Thank you for giving us a little bit of extra time out of your Friday morning as well. And I also want to thank the audience members. I want to thank folks' questions. Thank you, Dr. G.S. Potter. I'm also State Representative, Connecticut State Representative Robin Porter, some excellent comments and questions. I want to thank Martin Pratt in Philly as well, and John Erickson at RPI for those questions in that tracker. I wasn't aware of that, so we'll be following up too. So thank you everyone for joining this conversation, a Zoom-based micro summit that has been brought to you powered by the Council of State Governments Eastern Regional Conference Council on Communities of Color. I'm Charles Ellison. We will actually provide this recording and we will push it on the bnote.com. It will be available to view there. You can send it to your friends and we will share it on social media as well. Continue to look out for the next CSG CCC Micro Summit. We'll have another one in a couple of weeks. Go to the benote.com for more information there. And you can also listen to me on Reality Check on WURD Radio on Mondays through Thursdays, 10 a.m. to 1 p.m. Eastern Time. You can get a live stream at wordradio.com and also at facebook.com/forward for the Facebook Live TV or video stream. All right, that ends our panel. Thank you so much. This was fantastic. Please, everyone, please stay safe, very healthy out there as best you can. Keep those immune systems boosted and just be community, Look out for one another while you're out there, while we're all in this together through this pandemic. Good luck to everyone. We'll talk to you next time.
Thanks. Bye.
Thank you. Bye.